Hi, I'm Dr. Curtis Westersund from the podcast Teeth to Toes. And I want to thank you for all being here. Today's a really wonderful day. We have invited back a guest, Dr. Duncan Brown. And Dr. Duncan Brown is a world-renowned orthodontist. We're actually lucky to be able to get him on our podcast because I think he's going to Budapest at the end of the week. And he lectures and travels all the way around the world, teaching complex orthodontists in various different places. So let's give a real round of applause here. Duncan, thank you very much.
Thank you. Did I write that for you?
Yes, you did. Okay. I hope I read it right.
You did very well, yes.
I did very well. I tried. So Duncan was on a podcast earlier, and we were talking about diagnosing and how do you refer or when do you refer to an orthodontist and how do you actually start integrating dental care with an orthodontist and be able to solve your sometimes easy, sometimes difficult patients. But I want to talk today about things that I don't normally deal with. I have a TMJ-based or focused practice, and I don't see a lot of kids. And because I don't see a lot of kids, I send them to you, and you get to deal with all the problems, and you do a very good job. So today we're going to talk about kids. Now, one of the big things that parents will bring their kids in to see me or to have a consult with is typically a parent has some airway issues themselves, and after learning about their own airway issues, they say, well, my kid does that exact same thing, or my kid has a similar problem. They'll bring them into me. We might take a cone beam CAT scan, or we might just look inside the little gaffer's mouth, and we'll say, well, this is what we see. This is what we do. But I don't treat children when I'm doing TMD care. So that's why you're a valuable part of the team. So can you talk about how you diagnose children with airway issues?
Sure. First of all, let me rattle on a little bit about single-phase versus two-phase treatment. A two-phase treatment means you treat them as a kid and then you treat them again as an adolescent. The only people that do two-phase treatment a lot have got gray hair. And the reason for that is because it isn't taught in the postgraduate programs. The reason it isn't taught is the postgraduate programs are 2 or 3 years long, and if you're going to treat a kid, you have to treat it with a 7-year time frame. So when you guys are going out and looking for your orthodontist, you want to find out what they know about phase 1 treatment. They'll tell you they know a lot, but if phase 1 treatment to them involves putting in RPE, that's not enough.
Oh, can I just have you clarify? Can you tell me when you guys have acronyms? I believe RPE is rapid palatal expander. Am I correct?
Yes, that is correct.
Okay.
That is correct.
Carry on, sir.
Okay. So one of the things that the local dentist is on the front line of is you guys are the first guy that see the kids. And as that, you should be aware of how their growth and development is contributing to long-term problems like airway concerns. You'll see a lot of orthodontists that talk about either airway-centric or airway-friendly orthodontics. Those are probably pretty good guys to talk to because they are going to be dealing with expansion in kids. It's a good idea. When you see a kid, how do you tell, other than the fact that the parent has sleep apnea and wears a CPAP, that they might have a problem?
I don't know. How I can tell in an adult is I can do a home sleep study. but I can't do that in a child.
No, you're not going to run a level 1 sleep test in a kid. So part of your regular screening in kids should be a pediatric sleep questionnaire. You get it from the University of Alberta. It is 20 questions, and it has a very, very high sensitivity and high specificity. It's a great tool for a paper tool. It is self-reporting, which means the parent answers the questions. If they get a number of answers that are positive, greater than 14, there is an 85% chance that the kid has sleep disordered breathing and probably warrants further investigation. You should be doing that as a standard part of your practice in 5 to 7-year-olds.
Okay. So I believe they call it a PSQ, right?
That is correct.
The Pediatric Sleep Questionnaire. And now the parents fill that out because the parents are the ones observing the child as they're sleeping.
Well, it isn't just to do with that. It has to do with things like concentration at school, whether they wet the bed, that sort of thing. And it's very accurate. It has an 85% specificity rate, and that's proven in the literature.
Yeah, and it is a validated test that we can use. Good. Now,
and it's free.
And it's free, which, that's important if we're going to run a business.
Yep.
Now, you mentioned RPE. So can you speak a little bit about expanders? Everybody's all comes in, patients come in and say, well, a dentist gave me an expander, but they still have obvious airway issues in their adulthood. Obviously, expanders are not the be-all and the end-all. It doesn't mean that if you do an expander, you are suddenly cured of all of your problems. Can you explain more about an expander or what should happen?
Yes. No, expanders are not all of the problem. Airway problems in kids is a multifaceted concern. It involves diet, it involves posture, it involves allergies, it involves skeletal structure, it involves dental conditions, it involves a ton of things. And unfortunately, in a weekend course, for a lot of your listeners, are going to have attended a weekend course and come in here for 2 days and we'll teach you how to treat pediatric sleep disorders. The problem with those is that they are strictly focused on expansion. They provide very little information with respect to the other factors that are important in dealing with pediatric sleep questions. That's why the PSQ is so important. If you have a person that has a high score on the PSQ, then the chances are you shouldn't be treating them. You should be referring it to somebody that knows something about the other facets and has a team assembled that can deal with those things. Expansion is a good thing in kids.
Good.
Yeah, very good. But the science shows that if you expand a maxilla by a couple of millimeters or a few millimeters, you gain very little in terms of improved airway function.
All right.
The real advances in getting improved airway function in kids involves the combination of an ENT guy doing a TNA in conjunction with expansion.
TNA being?
Tonsils and adenoids.
Okay. So getting rid of lymphoid tissue.
Yes.
Okay.
The guys that are listening should have a relationship with an ENT guy. That'll be a real struggle.
Well, if you're in Alberta, that's a real struggle because I used to be able to refer directly to an ENT, but now we cannot. And so we have to go through the family doctor.
Correct.
And unless we're a surgeon. So that becomes the issue. But I totally agree that we should have a very close relationship with the medical side of health as well, including ear, nose, and throat doctors.
Yes, especially in kids. Especially in kids.
So expansion, typically, what, about 5 millimeters?
If you can get it, yes. I would think 5 millimeters may even be a little low.
Okay, how much would you rather be able to get?
As much as I could get. If I'm seeing a kid and I'm only getting 5 millimeters in expansion as measured at the molars, I don't consider that to be enough.
But it doesn't really help the airway. What helps the airway then is the airway helped by not just expansion, but the premaxilla, the front part of the upper jaw coming forward so that then the mandible can come forward? Am I hitting a note there?
Well, you're hitting a note there, except I don't buy the premaxilla part.
Okay, how do you explain it?
Okay. Here we got your local kid. We expand. We want to protract the maxilla so that the mandible can be advanced. And the science indicates...
Okay, hold on. You want to protract the maxilla? You said protract the maxilla.
Yeah, protract. Forward.
That's protract, meaning coming forward. Okay.
Yes. And that's not that difficult to do in a kid.
Okay.
And so if you can protract the maxilla in preparation for advancement of the mandible with a functional appliance, that's your best chance of creating a win in terms of sleep disordered breathing in kids.
As long as you take care of the other factors like lymphoid tissues, all those.
You got to do all that. You got to do all that.
Okay.
There shouldn't be anyone in your audience that's sticking an expander in a kid and thinking that it's going to solve their airway problems.
I'm sure there are a lot of dentists that hoped it will, but that's not proven. That's not shown.
No, it's not.
Okay. Now, bringing the mandible forward means that the mandible is actually, it has some leeway of where the condyle can sit in the TMJ fossa, in the socket, and you can only bring it forward so far. Do you have any rules with regards to that orthodontically?
Not really. I'm a fan of the floating condyle concept, where we believe that many dentists and many orthodontists think that the condyle position is fixed and is not changeable. The science shows that that is not true. The condyle position is not fixed, it floats. And the condyle structure and size and mandibular position is alterable by orthodontics. As soon as you believe that, then you can do all kinds of things that are not available to you if you don't believe it.
Okay.
So for your general dentist, they'll be familiar with things like twin block or BioBlock. Mm-hmm. Those are removable devices. They have all of the problems that all removable devices have, in that the kids lose them, or they don't wear them, or they don't wear them enough.
Okay.
So I am a believer in fixed orthodontic devices that create class 2 correction. Things like Herbst.
Okay.
That does work in kids. The trick is, science shows that if you do mandibular advancement with a functional appliance in a kid, it is not stable. The problem was that they never retained them. So if you're going to advance a mandible in a kid with a functional appliance, then they have to wear a functional appliance as a retainer at night.
All right.
For a period of years for it to be stable. So
what type of retainer are we talking about? Does it have a name or names?
Well, there's all kinds of them. I'm a big fan of tissue-borne functional appliances. I use a Frankel.
A Frankel, okay.
Yes, no one's ever heard of that.
I have heard of it because of you talking about it, but can you explain what that is?
Yeah. The advantage of a Frankel appliance is that it is a tissue-borne functional appliance. It makes the mandible come forward, and it allows the jaws to expand with growth while the kid is wearing it. They only wear it at night. And at night is a good time to wear it because that's when growth hormone is released. And what it does is improves tongue posture and arch width and length by nighttime wear. If it is done with a fixed functional appliance before they get it.
Okay. So it's not just, hey, a kid can be in an expander for 6 months and they're all done. Goodbye. Have a nice life. It's actually some complex integrated treatment where you're looking at a bunch of factors as that child grows to adolescence and then grows to adulthood.
Yes, we're terming it comprehensive early treatment. So instead of having traditional orthodontics looks at a 2-year treatment plan and then a 2-year retention plan. That doesn't work in kids. You have to have a 7-year timeline. And so you treat them aggressively for a year, you stick them in a functional appliance for a couple of years, you treat them again when they've got their permanent dentition for another year, and then you stick them in retention again for a couple of years. So if your orthodontic colleague is talking about only seeing kids for a couple of years or not providing retention to them while they are going between phase 1 and phase 2, you should be going somewhere else.
Okay. I love it.
Can I talk about one more thing?
Yes, by all means.
Okay, the current run in orthodontics is called skeletal expansion, where they stick in a expander and they screw it into the kid's jaw.
Okay.
And then they expand it, and they're seeing wonderful things with skeletal expansion. There is a role for skeletal expansion. I'm not sure what it is yet, but there is a role for it.
So this is expanding the mid-face, just the volume of the face that didn't happen during growth.
Yes. It actually creates a wider base of the nose.
Cool.
Oh,
so this is... Go ahead. Sorry.
Can I rattle on a minute? All right.
Yeah.
So you end up with a kid. He's 5 to 7 years old, 5 to 8 years old, and he has an airway problem. Most of the time it'll be in his nose.
Right.
You can expand the bejeebers out of his teeth, but if you don't expand his nose, you're not going to do anything. And that is the role of skeletally born expansion. It does work. It's not easy to do, and not everyone does it.
And it's all inside the mouth. It's not expanders outside the mouth. It's all internal.
That is correct. Some people combine them with face mask.
Okay.
So the jaw gets wider and moves forward at the same time.
Which is a good thing for your airway. It just makes for more airway.
It's a very good thing.
Can I make one comment? We talked about expanding these jaws, and there may be a genetic factor that, your parents gave you, grandparents, parents, you got this from your lineage, but it also may be how you grew. In other words, what we call epigenetics is what's on top of genetics that doesn't allow you to express a proper growth. And this orthodontics is all about then expressing the optimum genetic outcome that you could have if everything was working while you were growing.
That is correct. It provides the opportunity.
Okay. Well, you know what? This has been really great. Thank you very much. I think we need to, we've been talking about kids. I think we need to talk about the next time, maybe we should talk about adolescence or something. Would you be up for that? Another podcast?
Oh, yeah. Adolescence is cool.
I love it. Thank you so much. Well, I'm Dr. Curtis Westerson from the Teeth to Toes podcast. Thank you for listening, for joining, and we'll be back with hopefully more of Duncan Brown. Thank you very much.
Thank you, Curtis.